I'd like to welcome everybody to the next edition of the Controversial Topics in Hand Surgery Fellowship Debate Series. This has been a great series, and we're going to continue with it. So I'm going to share my screen to start off.
I'm not sure I understand.
Hello?
Let's see if this...
Was that Sanj chiming in?
Sanj or Siri, one of them. Okay, can you see my screen?
Yeah.
Okay, so I will, shit. Okay, so we'll get started with this. These are Jerry's intro slides, or this one at least, and I really like it. So I'm going to keep it in the theme that he has started, and we'll continue with this. So I'd like to welcome everybody to this week. Next month, we're going to talk about Dupuytren's contracture. That will be December 17th, so mark that on your calendar. So we've had a variety of different presentations over the past, and some of them have been more of a face-off, others have been more of a cage match type of variety. And so we'll see how this ultimately pans out when we're finished. Hopefully it's something like this, and we have some good interaction amongst the participants. So tonight it's going to actually be more of a tag team match. We're going to have two people cover different topics, and we'll have a nice discussion at the end. So reconstruction is our topic. And the two kind of broad categories are going to be microsurgical toe transfer and then distraction, lengthening, and osteoplastic reconstruction. And the teams covering the toe transfer are going to be the MGH and Harvard team and the Curtis National Hand Center team, with the distraction, lengthening, and osteoplastic reconstruction be a combination of Ortho Carolina, and then they'll tag in the University of Washington to finish things. So to introduce our participants, the MGH group is going to be presented by Nicole Agarwal, and Kyle Eberlin is going to be his mentor on this talk. Moving on to the Curtis National Hand Center, Joe Catapano is going to do the presentation, and Ryan Katz is going to be his mentor. So representing Union Memorial and MedStar at Curtis. Then moving on down south, Dr. Stephen Niedermeyer is going to do the presentation, mentored by Dr. Glenn Gaston, representing Ortho Carolina. And then we'll close things off. They'll tag into Dr. Gina Ferris-Eisner, mentored by Dr. Jeff Friedrich. So I've had a discussion with the University of Washington team about this, and they assure me that they are going to have an excellent presentation and be able to throw the knockout punch as we round up this. So when we think about causes of thumb loss, there's a variety, and we're going to focus on a couple that are more common. So congenital, trauma, infection, tumor resection, as well as thermal injury. But really we're going to talk about more trauma in this, or tumor resection. So our goals of thumb reconstruction are to create functional length, good stability with mobility to allow for opposition, sensibility, and then as good of an appearance as possible. And so it's not really a fair debate, because I think most people would say the ideal reconstruction is a toe transfer. But I'll tell you, there are no high levels of evidence on this topic, so we're really left with level 4 studies reporting good outcomes with a variety of techniques. And I really say the goal is to use general reconstruction principles for bony and soft tissue to manage your specific condition. And so when we think about the levels of amputation, we're really going to focus on what's been described as the middle third predominantly. So the metacarpal neck to the IP joint of the thumb. More distal amputations generally don't need any sort of reconstruction, and more proximal amputations around the CMC joint become a little bit more challenging. So we're going to focus on that middle level as far as the amputations predominantly. So the metacarpal neck to the IP joint, bone loss here can cause a functional problem. And so our goal is either to create an absolute increase in length with toe transfer, or a relative increase in length with distraction and web space deepening or other options. So mentioned here. So I'm going to give you 3 cases, and this will then turn over to the presenters. But I gave them these cases as kind of an idea of things to present. This is an example of a 52-year-old soft tissue avulsion of the dominant thumb, had attempted closure of the wound and necrosis of the skin flap. So he still has some underlying bony structure, but doesn't really have good soft tissue coverage back to about the MP joint because that skin flap is somewhat marginal. Here was the initial procedure, and then he was referred in with essentially necrosis of the skin flaps. Case number 2 is a delayed reconstruction. This is a 58-year-old, had a thumb amputation with an unsuccessful replant, and then was referred for revision reconstruction options here at this point. So proximal phalanx neck level, or proximal phalanx base level. And then the final case is a 45-year-old referred after a table saw injury to the dominant hand, resulting in amputation of the thumb and the index finger. So now we're back at the metacarpal neck, a little bit longer amputation. So these are the types of cases that we're going to think about and then discuss tonight with our various presenters.
Now, for the thousands in attendance and the millions watching around the world on HBO pay-per-view. Ladies and gentlemen, from Mandalay Bay, Las Vegas, let's get ready to rumble!
Okay, and so with that, I'm going to turn it over to Dr. Agarwal. You can share your screen and start the presentations.
All right, there, you should be able to see my screen. And like Dr. Hamrick just said, I think we have, my team and the Curtis's team have probably the easiest job because toes do make great thumbs. The data may not be out there, and part of that is because it's an easy case to make. You need a thumb, it's 40% of your hand function, it's all those things that we talk about, length, stability, motion function, cosmetic outcome. The thumb tends to do better. When you look at patient-reported outcomes for this, there isn't direct head-to-head data like he talked about, but there is data that compares toe transfers to either the contralateral hand or to amputations, and it's not as good, obviously, but it gets pretty close, and patients tend to be pretty happy with it. I think, especially when you compare it to replants, part of it is that patients who have had replants have never lived without a thumb, so they don't know what it's like not to have it, as opposed to when people get toe transfers, they've lived without a thumb, they know what they're missing, they know how difficult life is without their thumb. And so then when they get the toe, they tend to be pretty happy with it. They get that IP motion that is very key, and the length as well. And so here's a patient that had bad injury, had to get a previous abdominal flap. That helps you create a nice web space when you do your toe transfer. Ended up getting a toe, has good function, as you can see, long post-op. I'm going to talk about some things that'll kind of help make the toe transfer a little more accessible and simpler. Because one of the critiques about toe transfers is that it's a big procedure, involves microsurgery, specialized techniques. And one of the things you can do is get a preoperative angiogram. The blood supply, arterial anatomy of the toe can be quite variable, whether it be dorsal or plantar. When it's plantar, it changes your surgical operation a little bit. You have to usually vein graft on the back table, make sure you're not making an incision all the way down the plantar side of the foot. And with that, it can be very helpful to get a preoperative angiogram so you're not making that decision intraoperatively. Can prevent you from having issues later on down the road, and can help cut down on OR time. People talk about, well, is it cost effective? But if you look at the amount of time it could save you in the operating room, it probably is. And so when you get that lateral angiogram, here you can see clearly, if you look at the sequential images, you can see when the dorsal blood supply is dominant, helps you cut down your time in the operating room, making the surgery more accessible for people. And here, this patient that was 56 years old, had bilateral frostbite injuries to his hands, had lived without thumbs, severely limited. And I think it's pretty hard to argue that anything besides a toe transfer would be the right thing for this patient. Severe limitation function, needs the IP motion, needs to have as good of a reconstruction as possible, especially when you don't have the full function of your other fingers as well. And so when, in this patient and any patient, you're asking, which toe should we take and how do you inset it? And if you look at your big toe, most of us were dressed up, but we may have pajamas on. So you can look at your toes, you can look at this photo. Your big toe does angle slightly to your small toe. I've asked the orthopedic foot and ankle guys why this is. And I guess just as you wear shoes, it encourages your toe to move in that direction. And so when you're insetting it onto the hand and you're going to lose a little bit of IP motion when you do toe transfer, it's important to have that curvature going towards your other fingers. It'll help you get that pinch better and help you pinch to each one of your fingers. So that curvature is key, can help you get better results. Also, while you're insetting it, it's important to make sure you have adequate pronation. And if you're going to orthodecent the MP joint, you want to give yourself about 30 degrees of flexion. That'll help you get your pinch better as well. For the cosmetic outcome, I think toes certainly give better cosmetic outcome than any osteoplastic reconstruction or distraction osteogenesis. They look more like a thumb to improve your cosmetic outcomes. One of the things you can do is do a trimmed great toe flap. So you measure out the size of the thumb on the contralateral side, transpose that to your toe that you're planning on transferring, see how much excess skin you have, and you can trim that area off the medial side of the toe. That's not where your blood supply comes from, so it is an option. Can help you improve your cosmetic outcomes and at least plan for it whenever you're doing the transfer. When you actually get it up there, you won't always need it. Sometimes you'll get it up there and you say, hey, it looks pretty good, like happened in this case. But it's a good thing to plan for, so you're always ready for it and can improve your cosmetic outcome. As far as fixation, 90-90 wiring is a great option. It will get you good, stable internal fixation. You can help prep for it before you actually get you can place the wires before you actually get the toe up there, which is helpful. It's quick, it's easy, minimizes any periosteal stripping or undermining that you have to do. And so it's a great option, can help lessen the issue, gives you good stability on that thumb as well, because you have nice, strong internal fixation. So it gets you a stable thumb as well. As far as rehab that we use, we modified this from our replant protocol. I'd be interested to see kind of what other people do. I think important, anytime you have a big operation on your hand, you have to start moving the uninvolved digits early, and then slowly kind of move up from there. You're not going to start strengthening until about 6 weeks out. And to go back to that patient who had the frostbite injuries, just make another couple of points about why toes are a great option and other kind of techniques to help out. He liked it so much, he ended up wanting the other side done as well. So we did one toe. You saw his 2-month follow-up earlier. This is 4 months after that. And I think a critical point to make with this, because a lot of people that critique toe transfers will talk about donor site morbidity and wound healing problems on the foot. Key to this is if you make this incision on the medial side, it goes distal as possible, so you have enough skin, you'll be able to take that skin and close this without any tension. You can see how we mark the incision on the pre-op side and how it ends up post-operatively. Will minimize your donor site problems. Also, if you can preserve that MTP joint or that MTP surface as much as possible, people won't have as much pain and they'll be able to ambulate without issue. So those are kind of key things to think about. You can see how we did there. This is one of the older cases. So we used to go to the radial artery. Unfortunately, it required skin grafting across the joints because we like to skin graft over top for the anastomosis to reduce tension. Now, one of the things that can help cosmetically, help your function as well, is if you go into the princeps, then your skin grafts, up here rather than across the joint. It's another kind of technique to help the outcomes as well. And this is what that patient looked like a year down from his first operation. And here's a video of how good your function can be if you get 2 toes. So you can see his good function. He's able to oppose to all fingers there. Then we'll be able to see him make a fist here soon. So as you can see, patients are very happy with it. They do well. They have good function afterward. In summary, toes are great options. Look at that preoperative lateral angiogram. Use the ipsilateral toe to get the curvature right. When you're insetting, give it a little bit of pronation and 30 degrees of flexion at the MP if you're going to fuse that. Consider trim toe to help your cosmetic outcomes. 90-190 wiring is a great option. Gives you good stability, good internal fixation. Have a plan for rehab. I'd be interested to see what other people do for that. Make that medial incision distal so that you're able to close the foot and not have any donor site issues. Going into the princeps gives you a nice, good inflow and also allows you to put your skin graft not crossing any joints and graft over the anastomosis to improve your outcomes and not have too tight of a closure over your anastomosis. So we'll be interested to hear what everybody else has to say about it.
That was a great lead-off presentation. We, I think, all learned something and some pointers from that. So if you'll stop sharing your screen, we'll tag your tag team partner and let Dr. Catapano share his screen and give us some of his finer points.
Just trying to share my screen here. There we go. Okay, can you all see that okay? Perfect. So I just want to say thank you to Dr. Katz for letting me use these slides, and it's going to build off Nikhil's presentation and really focus in on what the donor site morbidity is, because I think everybody here can agree that toes definitely provide the best sensation, motion, and aesthetic result. And so it really becomes a debate about what are you giving up and whether that trade-off is worth it. So very quickly through the indications in the interest of time, ultimately the indication for us for a toe transfer, for a thumb amputation, is one that occurs at the proximal phalanx in cooperative, reliable patients. And you want to wait until the acute injury is healed and the patients have had time to think about their decision. Focusing in on the toe options, there's several of them, and we're going to talk about what we tend to use at Curtis sequentially. So second toe transfers, sometimes we'll use those for free parts, so toe pulps, IP joints. But as far as reconstructing a thumb, it's not really something that we like to use because it's small and bulbous in appearance. It has hyperextension of the MCP joint with hyperflexion of the PIP joint and DIP joint. And so we really think it doesn't provide the ideal aesthetic or functional results. So it's not something that we tend to go to. Wraparound toes have been done in the past, but it's been shown that they can fracture and there's also a lot of bone absorption. And so again, we don't use those as we also don't think it provides the ideal IP joint flexion. Great toes, as you can imagine, have very different dimensions than your thumb. And so in terms of using the great toe, unless somebody has small toes to begin with, we tend not to use the entire toe because of its bulkiness and size disparity. And so really, almost always we go with a trim toe. And the reason I put trim in quotations is we don't use a traditional trim toe while we trim the bone. We avoid trimming the bone because that's been shown to decrease IP joint motion. And so really it's a soft tissue trimming. And I'll discuss that a little bit in greater detail. So in terms of our preoperative workup, aside from ensuring the patient is appropriate and motivated, we don't order any imaging, which is a little bit different from the group at MGH. We do not routinely get angiograms. Our preference is to perform a thorough physical exam. If the patient has palpable pulses, then we're confident we can find a vessel there. However, in select cases with lower limb trauma or peripheral vascular disease, we will order an angiogram. In examining the recipient hand, we ensure they have an adequate web space, and that's an important point because we prefer not to do the procedures at the same time. So if they don't have adequate web space tissue, then we'll replace that tissue with free tissue transfer at an earlier stage, and then subsequently perform the free toe transfer. So in terms of a step-by-step process of how we manage the donor site and try and optimize aesthetics, preoperatively, we first template the contralateral uninjured thumb if one is available on the great toe. And this helps us plan out how much soft tissue must be trimmed and how much length we require from the actual toe so we can minimize the donor site morbidity. We then translate those measurements onto the toe to decide how much soft tissue should be trimmed medially. And that's part of what's being shown here is that width both on the dorsum and solar surface of the foot. Going further into that, you can see that swath of tissue medially that's been outlined based on our measurements previously. And that's the soft tissue that we're going to trim from the great toe to try and make the dimensions as close as possible to the thumb. In terms of minimizing morbidity from the actual foot, on the palmar markings, there's a few things that we want to point out. So firstly, notice that the V is biased laterally, and that's set to fall between the first and second metatarsal phalangeal joint. This is an important point because it keeps the scar off the metatarsal phalangeal joint to limit tenderness when the patient's walking, as that's the weight-bearing surface of the foot. Secondly, when we actually raise the toe, that tissue between the metatarsal joint and the actual first crease of the toe is raised quite thinly, almost like a full thickness skin graft, so that when it's transferred to the thumb, it limits the bulk in that area. And thirdly, we dissect the nerves quite a bit more proximally than the actual metatarsal phalangeal joint, and that's to ensure that no neuromas occur on the base of the foot when they're walking. And again, that helps limit donor site morbidity. And here you can see the toe raised, where the donor tissues are quite a bit longer than the actual toe. And right here where the arrow is that tissue that's raised quite thinly so it doesn't add to bulk on the thinner surface of the thumb. And here you can see the donor site. And aside from the fact that they're missing a toe, they have their entire metatarsal phalangeal joint there. There's no scar overlying the MTP joint. And these patients are able to walk nearly normally with their shoes on without significant pain. And here's that same patient with slightly different views. And here finally, you can see some photos of the thumb actually in place. And aside from being quite a bit broader, you can appreciate that if it wasn't beside his other thumb, this is something that somebody might not necessarily notice at first glance. So again, it's all about what that donor site actually causes in the patient. And so if you can see one of our patients here walking, there's no appreciable abnormality in that gait because we've preserved their MTP joint. And when you preserve the MTP joint, it's important not to violate the volar capsule and to leave a minimum of 1 centimeter of the proximal phalanx in place so that you can actually continue bearing weight on that area without affecting their gait. And up top, you can see pictures of their free toe transfer in situ. And here is another patient. This gentleman's a firefighter. And again, you can see that he has nearly normal gait. And certainly when you talk to the patients and ask them, they'll say that their gait has been minimally affected from their toe transfer. And here's that same patient tying his shoes with his free toe transfer. And that's really what this is all about. As you can notice, the breadth of the thumb, the dexterity that he has because of the sensation, and his ability to flex his IP joint is something that you're not going to be able to find anywhere else except with the free toe. And so our post-operative protocol includes placing a 9 French drain at the surgical site. We don't allow them weight bear on the foot for 3 weeks. From 3 to 6 weeks, we have them heel weight bear, and then eventually, if their scars have healed, then they can weight bear unrestricted after 6 weeks. The patients don't require any specific rehabilitation as we've left the first MTP joint in place, and we also place them on aspirin for 6 weeks. So in conclusion, what are the important considerations to minimize the donor site so you're not actually giving up so much to rescue the thumb and return function to the hand? And the first thing is scar placement. So make sure that scar is off the first MTP joint, and we actually like to use the left toe when possible because patients drive with their right foot. So in the event that there is a problem for them, it doesn't affect them too much when driving. Avoid painful neuromas by dissecting those nerves back to an area where they're not going to be on the weight-bearing surface of the foot, and preserve the first MTP joint so you don't affect their gait. And again, that's done by leaving a minimum of 1 centimeter of the proximal phalanx. And then most importantly, manage patient expectations. Educate the patients on what they are to expect, provide them photos of both good and bad results, photos of potential complications, and even place them in contact with patients so they can see what to expect. And now, just to address this question in case it comes up, we don't have a lot of time to go into it, but what do you do if you have an amputation more proximal to the proximal phalanx? And again, to limit morbidity, what we do is instead of going more proximal on the great toe, we'll use a 2-flap technique with either a free MFC or iliac crest, and then a free toe on top of that, which is shown in the picture here. And here's a list of those works cited, and hopefully I've convinced you that the donor site is not too bad and certainly worth giving up for a thumb.
It's a great presentation. 2 very nice presentations and compelling arguments for toe transfers. And I think most people would say a toe transfer does give you the best reconstruction. But it's a technique sensitive procedure. You've got to be comfortable with microsurgery. You've got to be comfortable with the harvest of the flap. But in the right hand certainly provides a excellent reconstruction. So next we'll move on to Dr. Niedermeyer. We're going to kind of switch gears a little bit here and realize that maybe not every patient wants to have their toe taken. Dr. Urbanik from Duke used to give a talk about not everybody needs a thumb, and he talked about many patients that had thumb amputations that never got reconstructed and functioned pretty well. So there is a different school of thought there. So we'll progress. Dr. Niedermeyer.
All right, can everybody see my like not presenter mode cheating slides? All right, great. Thanks for having me, everybody. I'm Steve, one of the hand fellows down here at Ortho Carolina. Thank you so much for the opportunity to present tonight. I keep hearing that our team kind of has an uphill battle against these advanced podiatry procedures that you've seen at the first start of this talk this evening. So without delay, I'll get started in our portion of our successful counterattack. So thumb reconstruction briefly, special considerations for thumb reconstruction, the restoration of length for opposition and the proper position of an abducted pronated thumb relative to the other digits, stable thumb, a mobile thumb, strength for pinch and grip, and to have good sensation. So basically you want to restore a tall, stable, strong, sensitive thumb. You basically want your thumb to be like sunshine from Remember the Titans. We'll start with thumb metacarpal lengthening, pioneered by Ivan Matev in Bulgaria in the 1960s. This technique can be utilized when the whole metacarpal or as even as little as 2/3 of the metacarpal remain. A great option for children because their regenerative bone typically fills in this bone defect after lengthening without the need for bone grafting. If the skin preoperatively is scarred or tight, you can do a web space deepening at time of exfix and osteotomy or afterward to deepen the web space for pinch and grasp. And the metacarpal length must be sufficient to accommodate an external fixator, but recent techniques, you can place that most proximal exfix pin within the trapezium if length of the stump metacarpal is an issue. Operative technique, you place the pins first to maintain your ideal alignment of the metacarpal. Definitely avoid the physis in kids if your metacarpal physis is intact. And then you make your osteotomy while limiting the amount of heat on your bone. Distraction takes place about 1 millimeter of distraction per day. This is something patients do at home. And parents can do it for the kids. The constant stress on that endosteum and periosteum stimulates the bone production, typically lasts about a month with achieving an approximate length of 3 centimeters to be gained. The rest of the period is different between patients, but typically 3 or 4 months to allow for that bone consolidation. You can use a bone stimulator during the consolidation phase if on follow-up x-ray your bone healing is a little sluggish. And then sometimes, especially in adults, there may be a need for interpositional bone grafting to assist in the formation of bridging bone. And then you can take advantage of that second procedure when you take off your external fixator to add internal fixation. These are Dr. Matev's results. This first study in adults looking at 35 metacarpal lengthenings. All of these thumbs were sensate, no fractures, only 6 required web space deepenings, and only 10 required interpositional bone grafting. His results in kids is great too. 7 metacarpal lengthenings in those ages 10 to 14. All sensate, no fractures, no web space deepenings. Although you could argue that that picture at the bottom could have used one to deepen his web space for grasp. But none of these patients had the need for metacarpal bone grafting. A case example from here in Charlotte, an 8-year-old who had amniotic band syndrome and syndactyly, who had reconstructions at ages 1 and 2 for his syndactyles. His primary complaint was that he couldn't grip a football with his right hand. So this is an example, not of our patient, but of the technique we utilize down here, a osteotomy, metacarpal lengthening, exfix placement with first web space deepening. Our patient at 3.5, 4.5, and 6 weeks with great consolidation of bone at 6 weeks seen, juxtaposing his before and afters, achieving wonderful metacarpal length, and the ability to oppose to all of his digits. And I don't know about anybody here, but I would not want to thumb wrestle that beast. Another case example is our 20-year-old female who sustained a left upper extremity trauma. She had a persistent radial nerve palsy, had multiple bony and soft tissue reconstructions. After she had regained suppleness of her digits, she underwent a PT to ECRB for a radial nerve transfer and removal hardware and metacarpal lengthening. Here is her progress at 1.5 to 8 weeks. You can see the beginnings of good consolidation there. Already during her lengthening phase, and probably in toward her consolidation phase, she's able to grasp a cup, and she did at 3 months undergo removal of X6 bone grafting and RIF. So going to our cases, I think for our case 1, thumb metacarpal lengthening would be an excellent option for her. Next, we'll talk about on-top-plasty. This is a term described first by Heinrich Soland in 1961 as on-top-plasty for index finger migration with intact neurovascular bundles. Through the last several decades, the use of this reliable technique has decreased. However, it can be utilized in the post-traumatic setting for delayed thumb reconstruction, or can be used in the acute setting as well. Here's an example of Soland's one of his first illustrations in print. Preoperatively, knowing your digit sensation can help managing expectations of your patient postoperatively. In the acute setting, you may not have that advantage, so relying on your intraoperative dissection and taking stock in your intact structures can help after surgery. Buck Gramco described this racket-type incision of the donor digit with a planned first web space deepening and mid-axial incisions along the recipient thumb, as seen here in a study done by the Mayo Clinic. During surgery, you temporarily ligate the ulnar digital artery, the ulnar common digital artery to the index finger, which is also the contribution for the radial digital artery of the long finger. You temporarily ligate this with a clamp, take your turn to get down to make sure that your long finger can stay perfused on its ulnar neurovascular bundle. And then at that point, you're okay to take your index finger for on-top-plasty. The dorsal vein arcade is typically enough for drainage after transplantation. You elevate the intermetacarpal ligament in the interossei. You cut the remaining proximal index metacarpal just distal to the metaphyseal flare to deepen that web space. And then once the donor digit is freed, it's transposed onto the thumb in a radially and palmarly abducted and pronated position. Internal fixation of the on-top-plasty allows for patients to have early range of motion ideally and no need for hardware removal afterward. Case example again here in Charlotte, a patient had bilateral upper and lower extremity pressor-induced necrosis. She underwent left index finger to thumb on-top-plasty. Here are her intraoperative pictures of on-top-plasty and first web space deepening. And you can see post-operatively her ability to abduct to her remaining ulnar 2 digits without difficulty. A quick review of the literature for on-top-plasty retrospective done by the group in up at Mayo Clinic, a 4-year follow-up. These reconstructions were done anywhere from 5 months after primary injury to 4 years. All patients' pinch and grip strength had improved minimally, but the patients were all satisfied with their results. Only 2 patients had difficulty with smaller objects like coins, and no one had any difficulty wearing flip-flops. So for case 3, I think an on-top-plasty for this patient would be a wonderful option, deepening that first web space with the index finger osteotomy and transposition. So in conclusion, for on-top-plasty and metacarpal lengthening, it's a safe and reliable non-microsurgical option for thumb reconstruction. Metacarpal lengthenings are great for kids especially, and for adults, and even an on-top-plasty can have a great functional and cosmetic outcome. Thank you for the opportunity.
Great. Thank you so much for putting that together and sharing that with us. That was a great explanation of another alternative as opposed to the microsurgical transfer. So to round this out, we'll do our final tag to the University of Washington, and Dr. Farias Eisner is going to close things out for the fellow presentations, and then we'll have some faculty discussion after that.
All right, can everyone see this? Thank you so much for the opportunity to present. I will finish out here with more non-microsurgical options for thumb reconstruction. We have no disclosures. So as has already been discussed, microvascular toe transfer has been considered the gold standard. But today I would like to discuss that might not be the case all the time. So while microvascular toe transfer may be a great option, it is not the great or best option all of the time. Patients that have thumb reconstruction may have specific goals or functional demands that cannot be met with a toe transfer. And so while this has kind of already been touched on, what are we really talking about here? So the middle and proximal third of the thumb, talking about defects of the middle third from IP joint to metacarpal neck, or is what the focus of this talk will be. We also will touch on just a couple other types of reconstruction. So what are our reconstructive goals? As has already been mentioned, these are the main goals and what our outcomes are really measured against. And so in a patient like this who has incurred a traumatic amputation of the index finger, dorsal degloving injury, as well as trauma to the web space, our goal is really to preserve mobility as well as to prevent adduction contracture. So in somebody like this, we might consider a posterior interosseous flap, which in our experience is a robust flap with a reliable pedicle that is radial artery sparing and a regional option for patients. And so here you can see that the donor site does need to be skin grafted, but you can maintain the ability to adduct and mobility. But when we have something like this, when we're talking more about the middle third, where we have both soft tissue and bony loss, we really need length. When we have the added complication of an AV fistula, what are our options? So options may consist of microsurgical toe transfer or an osteoplastic reconstructive option. So classically, this is described as a groin flap with iliac crest bone graft that can be performed in multiple stages with Littler's island flap to add sensibility. And another option would be an osteocutaneous radial forearm flap. So does a great toe really create a great thumb? Well, some of my colleagues have touched on the morbidity, and while some of the modifications can reduce that morbidity, there is still morbidity. Functional foot impairment was described after toe transfer in a review article discussing the functional donor morbidity after vascularized toe transfer. When we look at the biomechanics and gait are altered so that there's aberrant loading on the residual metatarsals. And this can result in callus formation and plantar pad erosion. In another review article looking at outcomes to toe transfers, weakness and push-off was noted in about 43% of these cases, and cold intolerance was noted in 28%. So if you are a rancher in Montana who walks 7 to 8 miles a day in the snow, these might not be good options for you. And thirdly, patients have personal and cultural preferences that may make this an unacceptable deficit. So what do we do in these situations? Well, we can consider an osteoplastic thumb reconstruction. So benefits, we have short operative time, hospital length of stay is shorter, there's minimal donor site morbidity, and it's not as technically demanding. And so for patients that want to get back to work, who are laborers and who need their thumb for their livelihood, this is a good option. This paper by Sabapathy et al. Is a very unique case study in which a patient underwent both a great toe transfer on the non-dominant hand and an osteoplastic reconstruction on the dominant hand. And what was noticed was that a well-planned osteoplastic thumb reconstruction can match microsurgical reconstruction in all functional activities. So 15-year follow-up of this patient demonstrates excellent abduction, opposition, and function of both osteoplastic and microsurgical reconstruction. So looking at some cases, a 46-year-old right-hand dominant male rancher sustained an avulsion injury to his right thumb while calf roping in Montana. A replantation was attempted but was unsuccessful. And so here's the unsuccessful replantation following debridement. And so this patient did not want a toe transfer and wanted to minimize surgical interventions as much as possible, but wanted a thumb. So this patient was a good candidate for an a osteocutaneous radial forearm flap, and you can see that that's marked out here. The radial forearm flap was elevated, preserving the LABC, and a portion of the radial cortex was also taken and osteosynthesized to the proximal phalanx. The LABC was neurotized to the ulnar digital nerve to allow for sensation. The donor site was skin grafted. And here you can see that the patient has a good result. The patient has met their specific needs, which was that the patient wanted length, and the patient wanted to get back to work. Second case here, 23-year-old right-hand dominant male who had end-stage renal disease, was dialysis dependent, and was actually on a kidney transplant list, sustained a motor vehicle accident incurring a traumatic amputation of the left thumb at the level of the proximal phalanx. Here you can see the AV fistula, and you can see the loss of soft tissue as well as bony loss. So given the AV fistula, we didn't feel that the patient was necessarily a great candidate for a great toe transfer or a toe transfer. And so alternative option here is a osteoplastic reconstruction as classically defined with a groin flap and iliac crest bone graft. So here you can see the markings of our groin flap. Iliac crest bone graft was taken with at the time of the elevation and fixated with internal fixation and a plate here. And the patient was happy with this, did not want any further procedures, and ultimately had a pretty good result. So what will our critics say about this? Well, it's not the most beautiful thumb, but beauty really lies in the eye of the beholder. So I would say in conclusion, the thumb with osteoplastic reconstruction achieves length, it achieves stability, it can achieve sensibility. No microsurgical skills are needed. There's short post-operative time and length of stay in the hospital, minimal donor site morbidity. And so really this is the thumb that you need. And we give it 2 thumbs up. Thank you.
Very nice presentation, Jean. I think I congratulate all of the fellows because they really did a nice job on presenting a topic. And as I said initially, it's probably not a fair, true debate or battle because in the ideal world, the toe to thumb transfer is probably good. But clearly that's not always an option, and some patients don't particularly want that. So I think we're going to open it up for discussion, and I've been scrolling through the list of attendees, and I've noticed Neil Jones is on the line. Neil probably has as much experience with toe transfers as almost anybody in the United States. So Neil, if you're with us and can hear us, would you like to share some of your thoughts on this topic?
Well, thank you. So, well, I think they were all very good presentations, but certainly in my practice over the last 30 years, I think you can't go by algorithms, and you also can't go with just saying, this is what I do, and therefore I'm going to do a toe transfer. So I do osteoplastic reconstructions, I do distraction lengthening, but there's no question in my mind that distraction lengthening was a massive revolution in the late 1970s, and similarly, the groin flap and the Littler flap were massive advances in hand surgery, but they really have been superseded, and so we have to not dumb down, and we have to provide the patient with all the options to see other patients who've had a toe transfer or distraction lengthening. And so when I see somebody for a thumb reconstruction, I offer them to meet with a patient who's had either a second toe or a great toe transfer, or somebody who's had distraction lengthening. And then they can make their own decision according to their profession and their expectations. Just one comment. We have not done an angiogram, I don't think, for a toe transfer for the last 20 years. You can assess the plantar and dorsal circulation just by using an 8 megahertz pencil Doppler. And in terms of sensation, and in terms of length, and in terms of the aesthetics, you cannot convince me whatsoever that these patients who have distraction lengthening have 3 centimeters of distraction lengthening. Once you get to that length, if there's an FPL still present, then there will be a flexion contracture of the thumb. So you're only lengthening the thumb, as you said. It's really an optical illusion. You're really deepening the web space. And some of these look as if they have, massive shark bites taken out after they have the 3rd stage Z-plasty done. But the most you can get most times is probably around 2 centimeters, maybe 1.5. And that bone has to be protected because the consolidate is not strong enough. And sometimes you can get a fracture a few weeks out. So you need to protect them for much longer to consolidate.
So thank you, Neil. Those are very, very helpful comments. Another thing I would add, if you're distracting and you have a proximal phalanx that's left, I always want to put a K-wire down that, and a relatively big K-wire, because as you distract, that proximal phalanx will flex and you'll get flexion at your MP joint and lose some of your distraction. So I think that's an important point if you're trying to distract and you have some of the proximal phalanx left. So a couple questions I'd like to ask Ryan. I was really impressed with your double free flap there for the more proximal amputations. Tell us how you do that, how long that takes you, because I'm not sure I have the ability to do 2 free flaps together and still be sane.
Yeah, so I can't take full credit for that case. I have the luxury of working with Dr. Higgins, who's a master microsurgeon, especially when it comes to the MFC. So when we have a patient with a very proximal, and I love raising toes. I mean, I just put me down at the foot anytime. So if we have somebody with a very proximal amputation, rather than going to the second toe, which would often be called upon for length, I'll raise the toe while Jim raises an MFC. And then both flaps come up at the same time pretty much. And we work together to do that case. In fact, we work together to do most of the toes at the center, just because it greatly facilitates the harvest and the inset and kind of tilts the odds in favor of a successful outcome. Because like the other side talked about, there is potential significant morbidity. So everything has to go right. But the double flap can be done because I work with great people at our institution and we do it together.
But where do you do the micro? Where's your arterial anastomosis?
Well, I think Nikhil pointed out that he likes to go to the princeps on the dorsal hand, and there's a dorsal carpal arch. So somewhere around the thumb for one anastomosis. And then the MFC, we love working on the radial artery if we can get there. So radial artery at the level of the snuff box. So these are anastomoses in parallel. So typically one to the princeps or dorsal carpal arch, and then one to the radial artery at the level of the snuff box in series.
That's a long day. One free flap is one toe is a long day for me. I can't imagine trying to do 2, but I do agree having a team is very helpful for this. Having one person prepare the thumb for the toe and another person harvesting the toe can make your day much better than trying to do it all with one team.
It would be a tough thing to bite off if we were doing it solo.
So, Jeff Friedrich, question for you. When you talk about the osteoplastic reconstruction with the radius, how much radius are you comfortable taking? When do you start worrying about the pathologic fracture of the radius later, and how do you protect that after you've harvested it?
Yeah, you don't need much, particularly as you saw from that case for the distal phalanx. I think the numbers that I've read are if you take more than 5 millimeters of the radial cortex, at least in terms of the radial to ulnar width, then you probably then you're at a higher risk for fracture. I tend to put a plate on no matter how big the radius osteotomy is, how big a piece of bone I take from the radius. It's the easiest volar plate you'll ever put on a radius. So it takes about 10 minutes to do. And then that lets me sleep pretty well over the next 6 weeks or so as they're rehabbing that. So I have less of a minimum and maximum of the radius because I'm prophylactically plating all of those.
A young Han Solo piloting around the
He is signed for years and years.
Glenn, question for you. With your on-top plasty, how much damage do you need to have to the index finger to consider that in your mind? Is it a proximal phalanx amputation? Is it a middle phalanx amputation? What is your real indication for that? You probably need some damage to the index finger, but how much?
Yeah, I think it depends on how much damage you got to the thumb as well. I mean, the bottom line is, the normal thumb gets to the index finger pretty easily around mid P2. PIP dysartic, it can still get there, but it gets tougher. So if you've got, a much shorter thumb, then really much damage at all, that thumb can't get to it very easily, and we would use it. But probably on average, most of the ones we've done have been injuries at least proximal to the PIP joint. Usually it's a P1 coming with or without a metacarpal head.
Yeah, that's a great case to do if you have a damaged index finger. I always feel better because that's essentially a pollicization. It's even easier than a pollicization for a kid that has a hypoplastic thumb.
Yeah, it's a little harder actually. For an MP dysartic, the one thing I dislike about the on-top plasty is the metacarpal head's much wider. So when you bring that over, it really does make it very bulbous at the end of the thumb if you take an MP dysartic and do an on-top plasty with the metacarpal. So I'd much rather have a P1 if you can. And you brought up a good point about pinning the the MP joint if it's there when you're doing a lengthening. The other thing I would say, we've actually have had 2 cases over the last 13 years of CMC dislocations with distraction lengthening. So we actually now will even consider pinning the CMC joint as well. That's been reported in other stuff. You lengthen forearms, you'll see radial head dislocations. You lengthen legs, you'll see a tib fib dislocation. So it's out there, but it can happen in the thumb as well.
Any questions that anybody else has for any of the faculty members or moderators or presenters?
So this is Nick Vetter. I trained at the Mass General back in the late 80s, not long after Neil left, along with Andy Lee. And my mentor, Jim May, was a big proponent of the great toe, as was Joe Upton. And so I came with that to Harborview in Seattle back in 1990. And Ted Hansen was the chief of foot surgery there. He was actually the chair of orthopedics. And he said, if you take a great toe, I will take your thumb. And so the number of great toes that we have done at Harborview over the last 30 years is a round number. So we find the second toe does just fine, or an osteoplastic, but we have not done a great toe at Harborview in 30 years, and our patients have done just fine, and they can run and walk and climb and enjoy the outdoors. So that's the West Coast, the Northwest view.
So what are your tips to make a second toe work well? It's obviously narrower than a thumb, but any tips that you have for?
So you need a good soft tissue base. So we'll do a groin flap often to make a soft tissue base. You take as much metatarsal as you need to get length, And obviously take the nerves and tendons, you pin the IPN extension for 6 weeks so you don't get the flexion. You tighten the extensors, and they work. They look like a second toe, but they work really well. That's all I'll say.
Fu-Chan Wei talks about doing a pulpoplasty of the second toe, and which is a fancy way of saying excising an ellipse from that pulp of the second toe. But I've found that actually at least narrows that bulbous tip and can really improve the appearance of that second toe transfer. But I will say that there may have been one great toe transfer at Harborview.
Jeff,
I may not know anything about that, but it may have happened recently. So.
A small number nonetheless, I guess.
I do think it's important to say that I think that we have moved towards a lighter surgical touch when we approach the foot than we had 30 years ago or so. And we really give a lot of respect to the metatarsophalangeal joint and go out of our way to harvest the great toe. If we're going to choose a great toe, and there's no doubt that the second toe is a better aesthetic donor site. But if we're going to do the great toe, we usually will take it at the level of the mid to distal proximal phalanx, even accepting a short thumb, which really people don't notice a short thumb. But we'll go out of our way to protect the metatarsophalangeal joint. And I think that is less morbid to the foot. And that's a big change that has occurred over the decades.
I think with all the thumb reconstructions, you'd rather be a little short than a little long. The long thumb looks funnier. You'd rather be a little bit short, and that's much less noticeable, I think, whether it's a kid or an adult that you're doing any sort of reconstruction on.
Another thing I'll throw out there real quick, Warren, that's a real simple thing. Before any of these, just I assume other centers do it as well, having them see a prosthetist and just get a simple opposable post that has 2 or 3 degrees of freedom to it is really in the patient's best interest. I've got a lot of patients who just have a simple prosthetic tightened thumb, and they do very well with it and never have any further surgery. So not all of these patients need surgery. So I think it's always worth trying that before any of these are entertained.
Yeah, these are all big operations. And so, you want to carefully approach that and make sure that the patient is invested in the procedure and the rehab and the recovery to get the most optimal outcome. So we're really approaching an hour. It's almost 9 o'clock on the East Coast and I guess 6 o'clock on the West Coast. So I again want to congratulate all of the fellows for their presentations and thank the faculty mentors for helping with it. I think it was really a productive hour and it was very educational. I learned several things that I think are very helpful. So as I said, next month the topic will be Dupuytren's contracture. In January, February, and March, we're looking at probably a couple elbow topics, possibly distal biceps or radial head injuries, because those are some controversies amongst those that we can discuss. And then we'll probably have one on nerve at some point in the spring as well. So Jerry, you want to say anything as we wrap things up?
No, not a whole lot to add. Thank you so much, Warren, for hosting and moderating. It's nice to sit back and just learn from all the faculty and fellows. So certainly really enjoyed it. As Warren mentioned, we are looking at topics for into the winter and spring. Probably going to have a nerve session, radial head, distal biceps. Certainly, if you have any suggestions, please let us know. But I really appreciate everybody doing this. I certainly have learned a lot myself. I think all the faculty and fellows have done a phenomenal job to make this as successful as it's been. So I really appreciate it. But just stay safe and certainly I welcome any input from anybody as far as making this better as we move forward. So really, thank you.
And the final thought is anybody that is on here that is interested in participating that either hasn't before or has and would like to participate again, certainly reach out to Jerry and or myself. As we're keeping a list of people that want to be involved, and we'll continue to build on that. When we were doing them every week or every other week in the spring, it was a little bit easier. Now that they're only once a month, they're spaced out a little bit, but we are keeping track of people that said they've been interested in participating. We'll try to include as many people as we can through the process. So this has been recorded tonight. It will be available on Handy for anybody that wants to view it again or any of your colleagues that did not get the opportunity to attend tonight. So we'll have this up hopefully within a week or so, if not right after Thanksgiving probably. So everybody have a safe holiday season, Thanksgiving, and I look forward to seeing everybody again in December.